Hello, good evening everyone. Welcome to the EUROGEN webinar series. Just a few brief words about what the European reference networks are. So this is the European Reference Network for Rare Urogenital Diseases and Complex Conditions, otherwise known as EUROGEN. And we work in close collaboration with other ERNs and also the main professional societies. So this webinar is actually delivered jointly with ERNICA and with the European Paediatric Surgeons Association. The reference networks provide highly specialist advice to healthcare professionals in the EU on patients with a rare disease or a highly complex condition that requires highly specialised healthcare. So we're really delighted today. We're dealing with the topic of bowel management in children with anorectal malformations, and we're absolutely delighted. It's an honour and a privilege to have here today Professor Daniela Iacobelli, who is a neonatal surgeon at the Children's Hospital Bambino, Gesu in Rome, Italy. And she's an expert who's been treating anorectal malformations in children for over 20 years. So we're delighted that she's going to share her experience today. And then we also have June Rogers MBE, who has over 30 years experience as a children's specialist bowel and bladder nurse, nationally and locally, and she's retired unfortunately, but we've managed to entice her back for this, and she has a specialist interest in anorectal malformations. So thank you enormously both for sharing your expertise with us, and without further ado I'll hand over to Barbara. I hope you all enjoy the webinar, and please feel free to ask questions. Thank you.
Good afternoon, everyone. Thank you, Michelle, for your introduction. The first reference of anorectal malformation was found in Babylon about 600 years before Christ. It was written in a stone. When a woman gives birth to a baby with a closed anus, the entire earth will suffer from disease. The quality of life in patients with anorectal malformations had major change in 1918 when Alberto Peña introduced the posterior sagittal anorectoplasty for the treatment of arm, and afterwards with the standardization of bowel management for treatment of fecal incontinence. We have learned that the surgical approach is only the first step of a long pathway. Many children do not obtain bowel control or a different degree of fecal incontinence. For this reason, these patients need to be followed during their life. Bowel management plays a pivotal role in the treatment of fecal incontinence. It is a program designed to keep patients with fecal incontinence artificially clean in the underwear. The regular motility of the colon is to empty rectosigmoid all at once and every day with clean underwear. To be fecally continent is necessary to have sensation inside the rectum, to have good motility of the colon, to have good voluntary muscles and sphincteric mechanism. Patients with arm often lack the intrinsic sensation to feel stall or gas passing through the rectum. The motility of the colon and the voluntary muscle and sphincteric mechanism can be also deficient. Patients with arm can be divided in three main groups. Patients that are totally continent with underwear clean. Patients that have voluntary bowel movements but occasionally soiling and or smear in the underwear. And patients that are totally incontinent. They don't have voluntary bowel movement and stool simply pass in the underwear. Three main factors influence the continence in patients with arm, type of arm, type of sacrum, and presence of tethered cord. In this slide, you can see how is the functional prognosis in patients with anorectal malformations reported by Alberto Peña. Patients with rectoperineal fistula, rectovestibular fistula, recto-urethral bulbar fistula, and imperforate anus without fistula have a good chance of bowel control. Patients with rectobladder neck fistula or cloaca with common channel more than 3 cm have a bad chance of bowel control. The second factor influencing continence is type of sacrum. A sacral ratio value equal or less than 0.4 represents poor prognosis for bowel control. A value that is equal or more than 0.7 represents good prognosis for bowel control. And the third factor influencing continence is the presence of tethered cord. So we have the two prognostic groups in arm, patients with good prognosis and patients with bad prognosis. Indicated of good prognosis are low defect, normal sacrum, non-tethered cord. Indicators of bad prognosis are high defect, poor sacrum, complex malformations, and tethered cord. Patients with good prognosis can have tendency to suffer from constipation, megarectum, and overflow pelvic incontinence in half % of the cases. Constipation is frequent in this group of patients because they suffer from hypomotility disorder of rectosigmoid. In these patients, the treatment consists in the administration of enema until the colon is completely clean, and then only laxative for life. The second group of patients with poor prognosis suffer from fecal incontinence, and there are the candidates for bowel management program. So we have seen that patients before starting bowel management need a contrast enema of patients, X-ray of sacrum and lumbar spine, kidney ultrasound to evaluate the presence of urological problems, and MRI of spine to evaluate the presence of tethered cord and or spinal dysraphism. The most important step to have success for the bowel management is to understand the specific type of colonic motility of patients. This is facilitated performing by a contrast enema. The enema can show two characteristic imaging, a dilated colon or spastic short colon. Children with dilated colon have hypomotility and large and floppy colon. These patients will need a large enema. In this case, no special diet or laxative should be given. Patients with spastic colon have a very fast moving colon. They have hypermotility. In these patients will benefit from a small normal saline enema, and also they will need medication such like loperamide to reduce bowel movement and pectin as a stool bulking agent. The second step is important to understand that every patient needs a different type of enema. Each one has a different type of colon in size and motility. Last but not the least, abdominal X-ray. With radiography, we can monitor the efficiency of an enema. We adjust the volume, concentration, and continence of enema according to the specific patient's reaction and the radiologic imaging of the abdomen. So, the take-home message: bowel management has improved the quality of life for children with anorectal malformations. The success of the program depends on the efficacy of enema and on the motility of the colon. It's important the collaboration of the family, the child, and the team care. And success is determined by trial and error. I will hand over to June now. June?
Good evening, everyone. Thank you for that, Barbara. I'm going to talk mostly about our step-by-step approach to managing children with bowel issues. I've got no conflict of interest. Bowel management should be proactive. We know that all children with anal rectal malformations can have a problem with their bowels to a greater or lesser degree. And so rather than waiting for a problem to develop, we like to take a proactive approach, and our aim is to enable children to be clean for starting school. And working with families over the years, we've developed a pathway from birth about a proactive bowel management, and this pathway can be downloaded from the Bladder Bowel UK website for those of you that want to have a look at it. So our proactive step approach starts off from weaning with a dietary and fluid adjustment. We promote early potty sitting. Then we look at oral laxatives for children who have problems with constipation. We would then go on to rectal laxatives as necessary, then follow it with rectal washouts, the MACE or the ACE procedure, and the stoma as necessary. So starting off with diet and fluid advice, I think it's important that families are advised regarding the most appropriate diet. And as Barbara mentions, it's important whether they've got a fast transit or a slow transit. For example, if you have a child with a slow transit gut who's a poor drinker and doesn't have much fluid, then insoluble fibre may not be the best type of fibre for them to have. For children who we have a predisposition to develop constipation, we'd encourage fruit rich in sorbitol, which is a natural laxative, and the families are advised about monitoring the stool in terms of the consistency and the frequency, and to make dietary adjustments as necessary. And certainly a good fluid intake is encouraged. And we know there's not a lot of clinical research about the benefit of probiotics, but we actually have found in practice that they are beneficial. We promote early potty sitting from weaning. We have a closed Facebook group, and one of the mums posted on here, here's Caleb, who's 10 months. He does a poo every day sitting on the toilet. She's been doing this since he was 7 months, because he got very constipated when started weaning. And we find that once the mum stopped breastfeeding and introduced cow's milk, that can be an issue. And really, we found it's really helpful, not just in terms of the constipation, but is anticipation for toilet training as well. So we really try and empower the parents to manage the child's problem as much as possible. So we tell them all about laxatives, how they work, what the minimum and maximum dose should be. They're advised not to stop taking the laxative unless they're advised by a healthcare professional. We give them a Bristol stool chart so they know the type of stool they should be aiming for. And if oral laxatives are not effective, we would then go on to rectal laxatives, enemas or suppositories. Then, if despite all our best efforts, the child still had problems with soiling and we weren't able to resolve the underlying constipation, we would then look at transanal irrigation. And we can start this from the age of 3. We try and give the parents a choice of what system they want to use. We although we tend to use mostly Peristeen, there are some children who don't tolerate the rectal catheter and balloon, so we offer them the Q4, which has got a cone. So as much as we can, we try and give the families choice. We know there's increasing numbers of young adults with learning difficulties who benefit from rectal irrigation. So we've developed 2 resources, the Easy Read Guide to Transanal Irrigation, which explains to them what it's all about, and then the step-by-step guide to using Peristeen. And again, these are both freely available to download from the Bladder Bowel UK website. So in terms of transanal irrigation, we encourage the children to be taught at home, because then you can make adjustments about where their toilet is and where the sink is and that sort of thing. So enable them as much as possible to get comfortable using it. We start daily and gradually increase the volume to a degree that they can actually tolerate. Usually it ends up around 200 to 500 mils. And to start off with, we may keep them on the oral laxatives and adjust as necessary. We would introduce rewards as much as possible to encourage the child to take part and to do all the necessary things like, you know, encourage them a good fluid intake and get them into a good daily routine. And if things go well, we will then may stop doing it every day and may do it every alternate day. And we aim to encourage the children to be as independent as possible and teach them how to do it by themselves as soon as we can. For those children that rectal washouts don't, they're either not tolerated by the child, because some children will just don't like anything touching their anus, and that's fair enough. Then there is the ACE procedure or the MACE procedure, and as you can see, it involves a surgical procedure, but increasing we find this is happening less and less, and the majority of children do really well on the rectal irrigation. For some children, despite all our best efforts, nothing seems to work, and so for some small number of children they may end up having a stoma. But I think it's important we don't look at this as particularly a negative thing. For some children it's the first time, they don't have to worry about soiling or having accidents. They can just go about their daily life and go swimming, etc. And so we don't necessarily think a stoma is a negative thing for a child to have. It can make a huge difference to their health and well-being. I mentioned before about children with additional needs, and we have developed a closed Facebook group for children with Down syndrome. We know children with Down syndrome have a higher instance of anorectal malformations, Hirschsprung's disease, so we have a closed Facebook group where we can provide lots of advice and support. So the take-home messages are that bowel management should be proactive. We shouldn't wait until the child's become constipated, for example. We should be actually monitoring these children on a regular basis, and early intervention is the key. And really it's about empowering families so they can recognise when problems are developing and intervene quickly and early. Some children may require the support from a multidisciplinary team, and our ultimate aim is to get the children clean for when they start school. Thank you very much. We're now going to go over to questions, but before we start, I have a question for you. We mentioned about multidisciplinary team, and the issue as well for a lot of the children, they're seen in a tertiary centre a long way from the community where they actually live. And so what we think is important is the integrated care and the continuation of care for when they go home. So it's just be interesting to see how many of you have a community-based specialist nurse that can actually support the children when they're not at the hospital. Thank you very much.
Okay, yeah, so I'm going to, thank you, June. I'm going to run that poll now, so no need to put anything into chat or questions. I'm going to put it on screen. You should be able to click Just give me 1 second. I'm going to launch it now. So you should be able to choose yes or no. So I'll give you a few 30 seconds to just respond to that. Once the numbers settle down, I'll stop it. Yeah, I think that's. I'd like to say it stopped, and it's just adjusting itself slightly again. Okay, so 5, 4, 3, 2, 1. I'll close it there. I don't know if you can see the results, June.
No, sorry.
Okay, well, it's come out 50-50 exactly. So.
Oh, okay. That's good.
Okay, so I shall hide those. Okay, then I'm going to go into questions back with Barbara, yes. So I'm just going to give Barbara back permissions to share the screen. 1 second. You should see that now, Barbara.
Okay. Okay. The X-ray of abdomen can give us a lot of information. So look at the radiography. This patient is a child male, child female, adolescent male, adolescent female.
Okay, I'm going to put that poll up now. Make your choices. So a few more seconds. Okay, again, 5, 4, 3, 2, 1. Close. Show the results. Can you see them, Barbara, or not? Barbara,
I don't see.
Don't see them. Okay, I'll read them out. It's fine. So, child male, 16%. Child female, 18%. Adolescent male, 18%. Adolescent female, 47%.
Okay, very good. Is the right answer. This patient is an adolescent female. In fact, in the upper part of the radiography, you can see the bra. Obviously, it is a joke that, however, underlines the importance of an accurate evaluation of the radiography. Okay. I don't move. I can have the next slide, please.
Do you want to move to the next slide, yeah? You should be able to move it. Can you move it, Barbara, to the next slide?
No, I don't see.
Okay. I can't move it. I think you've got the slide. So here we go.
Okay. Now I see. Okay. So this is the radiography of 5-year-old boy with arm treated on rectoperineal fistula. These patients had a good sacrum. You can see in the abdomen, in the rectosigma, hard stool inside the rectum and inside the left colon. What initial treatment do you propose? Diet, laxative, disinfection, then laxative, I don't know.
Okay, I'm going to launch that now. Slide 1, I think. Okay. Okay, got about 3/4 of the people who voted. So 5 more seconds. Anyone else who wants to? Okay, I'm going to close it now. Okay, let's show the results. So, Barbara, those results were diet, 6%, laxative, 4%, disinfection, then laxative, 90%, and 0 don't know.
Okay, very good. Obviously, this is a patient that has a good prognosis, a good satum. So we start with this impact treatment with enema and then laxative for life. Darren, the second, the new.
Can you move? Yeah, you better move the slide on again, I think, hopefully. I've stopped sharing the poll.
Okay, perfect. So this is a contrast enema of a 12-year-old boy with fecal incontinence, bladder neck fistula. What treatment do you propose? Laxative, small enema, 200 milliliter normal saline, large enema, 400 milliliter normal saline, more glycerin, and I don't know.
Okay, I'm going to run that now. This one looks a little bit closer. Another 5 seconds. 3, 2, 1. Close. Okay, these results were laxative 9%, enema 200 ml normal saline 49%, enema 400 ml normal saline plus glycerin 30 ml 38%, and 4% don't know.
Okay. Allora, this patient has hyperkinetic colon, and we start the bowel management with small enema with saline solution.
Go on to your fourth case.
The same patient reports stool accident during the day after 7 days of small enema. Look the radiography. What do you do? Increase enema, hadid loperamide, hadid laxative, I don't know.
Okay. Just 3B, yes. Okay, another 10 seconds, I think. So 5, 4, 3, 2, 1, and close. So those results, Barbara, are increase enema to 500 ml plus 20 ml glycerine at 35%, add loperamide 47%, add laxative 14%, and 4% don't know.
Very good. The majority answer hadid loperamide, and this is the correct answer. Hadid loperamide to slow down the colon. The next. Okay. This is the radiography of a 10-year-old girl operated on rectovestibular fistula. What treatment do you propose? Diet, laxative, bowel management, I don't know.
Okay, here we go.
You can see the hard stool inside the rectum and inside the colon.
Okay, so 5, 4, 3, 2, 1. Close. So those results are diet 2%, laxative 31%, bowel management 65%, and 2% don't know.
Okay. Very, very good. You are expert. I understand that you are all experts in bowel management. And the answer right is the bowel management, obviously, because this patient has a poor sacrum. In fact, you don't see the sacrum in these patients. And for this reason, the patient has poor prognosis. The treatment is the bowel management for life. Thank you. I finished my presentation. If you have any questions, I can answer.
Okay, so Barbara, I've sent you a few questions on already. I don't know if you can see them.
Yes.
Great. So I don't know if you want to start going through those.
Okay, I can read. Any role of presacral mass in the bowel control? Okay, if presacral mass have a tetrad cord or poor sacrum, these patients have a poor prognosis. And so we start with bowel management in these patients. The second one, I'm strongly, Rolle, Udo, I'm strongly against stereo X-ray. Yes, I understand, Rolle, what do you say, but I think I don't use ultrasound because I prefer X-ray because I need to compare the same imaging. In some places in Europe, they do ultrasound. But I think if you have the capacity to do ultrasound by yourself and you can compare the imaging, do it. Obviously. Do you add glycerine to the normal? Yes, allora, I use normal saline and I did glycerine 20 milliliter for 500 milliliter of saline solution. What is your protocol for impaction? Okay, I start with 2 daily enema, 1 big enema with normal saline in the morning, and in the afternoon, another 1 enema with glycerin. After 3 days, the patients do a radiography to evaluate the efficacy of enema, and after 3 days, another radiography. If colon is clean, we can start with the laxative.
Okay, I think I'll send some questions to June as well. June, I don't know if you put your camera back on as well, if that's okay.
Okay, I can't see any questions. Let me have a look.
Okay. So if you look on the right-hand side, if you see the question, there should be questions grey bar.
Yeah, I'm trying to. Okay. Okay, they're tiny. I'm just trying to scroll through them.
If you click on the little arrow to the right-hand side, and if you click that, it will make it bigger.
Okay.
On the grey bar itself, on the right-hand side of the bar.
Yeah. No, never mind. I'll have a look and see what I can see.
I can read them out. I can read them out.
Yeah.
I think these are for you. So I think it says, what type of laxatives do you use?
Okay, it depends very much on how the child presents. If initially we start with a macrogol, something like Movicol, and then we would add in a stimulant laxative as necessary. So it's very much individualized to the child.
Okay, and then a follow-up. What are the ingredients you use for an enema?
I would either use proprietary enema, a microenema or a phosphate enema, or when we do the rectal irrigation using peristine, we just tend to use tap water.
Okay, some of these I'm not sure which one they're for, so I'm going to read them out. Basically, you can both answer. You can answer. So next one is from the same question again. Constipation is incurable but manageable. What do you think?
Well, from our point of view, we can manage it, but I think the important thing is to proactively manage it. So we try and identify those children who are going to have a problem with constipation while they're in infancy. Particularly, the trigger is weaning. So that's why we have an early intervention, because what we know is that long-standing constipation, if it's not managed proactively, the child then can develop acquired megacolon megarectum, which is going to make the problem worse. So I think a proactive approach, we can manage it and prevent it becoming a really chronic, long-standing problem, which is often the issue. And I know I would get children referred to me, you know, in 8, 9, and 10, and you know, still having to wear pads, still having to have still having accidents because you know, they haven't been proactively managed. So I think if its intervention is early, then we can definitely get on top of it. And you know, as the questioner asked, yes, we can control it.
Okay, thank you. What are we up to there? I've lost my place. Okay, what is the difference between enema, irrigation, and flush?
It depends. They're all the same. It depends. If you think of it's whatever is put into the rectum. It could be an enema, which is usually a small amount. If you look at irrigation, that usually can be hundreds of mils. And if you think of an ACE procedure, that's an antegrade, so the bowel is flushed from a stoma, a catheterizable stoma in the colon, so the bowel is flushed from the top down. With rectal irrigation, it's flushed from the bottom upwards and goes into the colon, whereas what we would call, I guess, in England as an enema is only is in the rectum only. It doesn't go further up. It just works on the stool that's been retained in the rectum, whereas a washout, what we would call a washout, would actually go the rectum and then the descending colon. I hope that explains.
Okay, yeah, I guess if Farron, if it doesn't, then please.
But they're all very much, it just depends the amount of fluid that you use and whether you do antegrade from the ACE procedure or rectal irrigation from the bottom.
Okay, thank you. So next question is, do you start bowel management after surgery in small babies?
Straight away, we would, the parents would be advised what to look for. Often after surgery, obviously, then it takes a while for the bowel to get into a pattern. And so that would be monitored. And I think, as I say, it's the weaning that's often the trigger. But I think, yes, they would be looked at and managed and followed up, and that's what we found is the key, particularly with the group of children that I'm currently working or supporting, that we advise very early on so the parents know how often the child, because often people don't know what's normal. So I think it's important that we empower the parents. We tell them what's normal, and then we would say, if this happens, you do this. If that happens, you do that, rather than waiting until the child hasn't had their bowels open for, you know, 2 weeks or something. That I think it's important that the parents know what to expect, what's normal, and when to ask for help.
Okay, there was just a qualification to that question, actually. I missed it. Sorry, it's further down. It says, so do you start bowel management after surgery in small babies, meaning when you have poor prognosis factors and if you repair the patient completely? Whatever that changes your answer, I'm not June, I don't know. But...
Yes, because poor prognosis, I presume they mean in bowel control. Yes, most definitely, because these are the children that potentially would be having peristine or rectal irrigation by the time they're 3.
Okay, next question. How are your experiences with Navina Smart?
I personally haven't used it, so I don't know. I've heard a lot of good things about it, but I haven't used it, so I can't comment.
Okay. What's we got here? When do you start bowel management in an impacted patient with poor bowel control prognosis? Should it start after disimpaction?
Oh yes, you cannot do anything until you've disimpacted the child. So disimpaction comes first, and then we would start a bowel management program, and that often can be trial and error, because what works for one child doesn't necessarily work for another child. So we have a plan A, a plan B, and a plan C. So we start, and we, as I say, we do a step-by-step approach. And some children, once you've disimpacted them and got them on oral laxatives, you've got them, and the important thing is getting them sitting on a toilet and getting them sitting in the right position, so that with their knees bent, their feet flat, and I think this is important, and that's why we start very early on with infants sitting on a potty, getting in the right position so the pelvic floor is relaxed, teaching the child how to push, how to bear down, etc. That's all part of the bowel management program.
Okay, just a few more. So the next one is how you prepare NS at home, which I'm guessing is Navina Smart again, is it? I don't know, but that's NS.
I'm not sure, as I say, I have no experience of that.
Yeah, so Farad, if you want to clarify that, I'm not sure if that's what you're referring to. Next one, how do you manage diaper rush?
Sore bottoms are a nightmare. Again, we can almost predict that once children have had pull through, their bottoms are going to get sore. So proactively use whatever barrier creams that you have available in wherever, which part of the world you live, and proactively don't wait until the bottom's sore, but use a barrier cream at every nappy change.
Okay, 2 more questions now. Can we associate laxatives with enema?
I'm not sure what that means, but yes, some children have oral laxatives and they have enemas as well. So
okay.
It's whatever combination works for that child.
Okay, the last question at the moment. What is the dose of glycerine in bowel management program, and how much is maximum dose of normal saline that you can give?
I think Barbara perhaps needs to answer that one.
Did you catch that, Barbara?
I use until 1 liter. 1 liter in enema. You hear me?
Yes. Yep. Okay. That's great.
Yes. I want to only say about enema and laxative. I don't agree with June in this point, because I never prescribe enema and laxative in the same patient, because enema cleans the colon, and we hope that the colon moves slowly and allow the patient to be clean. By giving laxative, the colon moves faster with possible accident. For this reason, I never prescribe laxative and enema at the same patient together. Sorry.
No, that's fine.
This is my opinion.
Oh, yeah. And I'd say every child is different. And so if despite all our best efforts, laxatives alone don't work and enemas alone don't work, then we would try them both together. But as you say, it's not common.
Okay, next question. What about stoma product to prepare the perineum? Does that make sense?
Is that to prevent soreness, or I'm not sure.
I don't know. That's just what the question I've got, so I'm not sure. So
sorry.
Yeah, I know Romy, I know you kind of was asked, said thank you, but if you want to maybe just kind of expand on that question, that'd be really helpful. Next one, some centres, I think it's just a comment basically on the previous question. some centres advise 1/3 of contrast used for the contrast enema study. If that makes sense to people. So yeah, so just to clarify that previous question, what about the stoma product to prepare the perineum to prevent irritation after bowel continuity? Is that restoration maybe?
In terms of putting like a wafer over around the perineum, I'm not sure.
Yes.
In my experience, yeah, in my experience, unless Barbara wants to answer that question.
No, I don't use nothing.
Okay. Okay. Apparently that is done in the USA. So this person saying. Okay, I think that's kind of all the questions just about done at the moment. So I've got a lot there. Sorry, so we've gone on. There's about 7 minutes to go. If anyone's got any other questions, please put them down. If I've missed anything, you want to ask it again or to clarify anything, please do so now. We'll say if you've got any further questions that you think of afterwards, we don't have time for now, please send them through to me and I will pass them on to the presenters and we'll get you an answer in time. Just while we're waiting for other questions, so I say thank you everyone for joining today. We've recorded this webinar, so I don't have any problems. I know one person had a problem seeing the slides. If anyone else has any issues, the recordings will be available tomorrow. I will send out the links to all the registrants basically. You'll be able to find them on the links on our GoToWebinar website, on our GoToWebinar site, and we'll also put the video onto YouTube as well. So please do check our YouTube site out and subscribe if you can. We put pretty much all of our webinars on there. I'll also check out our EUROGEN website and other websites, ERNICA and EUPSA as well. Our EUROGEN website has all the kind of forthcoming webinars in the EUROGEN program, and including further ones for the ARM webinars as well. So over a few more things here. Let me just read these. So one here. What are the complications seen by you in diverted stoma or loop stoma? I think that would be.
Oh, I think that would be a question for Barbara, perhaps.
Prolapse, inverted stoma, and stenosis.
Okay. Yep. Okay. I think that's kind of everything for now. So everyone, people saying thank you to you both. I'll say thank you to you both as well for presenting today. It was two excellent presentations and answering a lot of questions as well. So thank you. I don't know if you got anything else you want us to say to finish off, or?
No, I just noticed a question about children with a learning disability and their ability to become continent. Most definitely, I'm working with a group of children with Down syndrome now who've got Hirschsprungs or anorectal malformations, and I've just worked with two families of two young children, and both we managed to get clean, toilet trained for starting school last September, and they were 5 years old. So there is no reason why, because the children have got a learning disability, we can't get them toilet trained and clean.
Okay, yeah, thank you, June. I missed that one in the midst of these other ones. Yeah, great. So again, thank you, June. Thank you, Barbara, very much. Thank you to everyone for attending. So any other problems, issues, questions, please just get in contact with me. We'll be advertising our next webinar very soon, in the next couple of days. So I'll be sending that to everybody who's registered for this one. We'll get the invite for that one as well. So yes, thank you very much all, and take care and have a good evening. Thank you.
Thank you.
Thank you. Thank you. Bye-bye.
Bye-bye.
Bye-bye.